Then we also found out that those who perceived communication from the healthcare provider as good, having 3.5% more likely to be able to be satisfied. However, the level of education was not found to be associated with the patient satisfaction. We also found out that the odds of a patient satisfaction was 2.2 times higher among those who trust the healthcare providers compared to those who do not trust the healthcare providers. So as we conclude, these are some of our discussion from the findings. So a higher satisfaction rate was recorded among the females in contrary with the males. We also compare this study with the one for Bena. He found out the other way around, where the males were more satisfied than the females. When we come to the healthcare related factors, the ones we talked about, waiting time, the availability of drugs, as well as the services the facility can provide, we found out that 91% of the study participants claimed to have received their ordered drugs. This recorded a very high percentage of availability of drugs in the Nakuru Level 5 hospital. Also, we found out that there was a higher percentage of participants who took between 30 to 59 minutes to be attended to. That falls between less than 1 hour, but that is only 46% compared to those who claimed to have received services after 1 hour. According to Prakash, time taken to deliver healthcare services takes an important role in determining the outcome of the patient satisfaction. With the COVID-19 related factors, we found a very high percentage of the observance of the protocols. We have hand washing and use of soap, and also the hand sanitization. We also had a higher percentage of observing the physical distancing. So this is in line with a study in North Shore in Ethiopia, where patients were able to obtain hand sanitizers and cleaning materials during the COVID-19 period to prevent them from getting the virus. So we also recorded a higher percentage of social distancing, as I had said before, and this is similar to a study conducted in DC Referral Hospital, where the patients were able to observe the social distancing, So, however, with the provision of masks, our study recorded a very low percentage of 7.5% provision of masks to the clients, and some expressed their feeling that they needed to be provided with this protective material to prevent them from getting the virus. Moreover, 92% of the study participants reported that the healthcare providers put on masks, yet the clients do not receive. In conclusion, we would like to conclude from our study that patient-related factors like age, gender, marital status, and education level, and also the monthly income influence patient satisfaction. We also conclude that all the clients, married individuals, and those with a higher education level have a higher satisfaction rate compared to those who do not have that. Then the healthcare facility-related factors like waiting time, the mode of payment, availability of healthcare services, communication between the healthcare provider and the client were found to be important in determining the patient's satisfaction. We also found out that patients who experienced shorter waiting time were highly or more satisfied compared to those who waited for more time. This also reflects with the availability of drugs as well as the health insurance or free healthcare services, the mode of payment. Also, the COVID-19 related factors like hygiene, hand hygiene resources, physical distancing, and all the protocols were found as important in affecting the patient satisfaction during the pandemic. Patients who had access to these protocols recorded higher satisfaction compared to those who did not access the preventive protocols. Our recommendations to the facility and also to the government: the institution should implement strategies such as adoption of standard emergency department, the triage department. This one will help the facility to be able to reduce the waiting time and the turnaround time, and this would affect the patient satisfaction positively. We also recommend regular customer satisfaction assessments and target customer feedback plan, which should be introduced in the hospital as we talk about COVID-19 and also as we move forward with the healthcare provision. We also recommend the nurses and other healthcare workers who are involved in management of clients, especially during the pandemic, to occasionally sensitize the clients, explain to them the importance of COVID-19 prevention protocols. Also, on the vaccination, the hospital can organize a vaccination outreach or a camp programs in the wards as well as the outpatients, so that to be able to increase the rate of vaccination and positively fight the pandemic. The hospital management can also consider allocating some funds to the facilities to be able to provide the PPEs to the clients as well as to the healthcare providers. Also, the periodic patient satisfaction surveys can be conducted in the hospital, as they are important in establishing the quality of services provided in the facility for now and the future. Also, the healthcare providers can offer special attention to the older clients. You remember the older clients who are more satisfied. They can offer more attention so that they can meet their needs during consultations and treatment. Thank you. That's our presentation.
All right, another round of applause for Brenda. Great. So thank you for your presentation, Brenda. We are going to have another presentation, and then we can be able to take questions. So we have Eunice, who will be presenting online. Eunice, if you can hear us, and if you're ready, you can be able to share your slides. So Eunice will be talking to us about birth outcomes and after cesarean section, so an observational cross-sectional study. So that is what we expect to hear from Eunice. So Eunice, your voice is not yet, we can't hear your voice, so you can try speaking, then we can see if our audio is okay.
I am speaking. Can you hear me?
Yes, we can hear you clearly, so we'll upload your slides and then you can be able to proceed.
So I'm unable to share my slides because the previous presenters still sharing. So maybe she can stop sharing so that I'm able to share.
All right. Can you stop sharing? Can you try sharing now, Eunice?
Yes. Are you able to see my slides now?
Yes, we can see your slides.
Okay, thank you.
All right, so you can proceed with the presentation. You're welcome.
So all protocol observed, good morning. So my name is Eunice Sondego. I'm a family medicine resident at Kabarak University. I'm going to present my study. I did a study on maternal and neonatal outcomes of trial of labor after cesarean section in a low resource setting in Bomet County. As my introduction, cesarean section is a life-saving procedure when medically indicated. And Craigin coined a dogma that once a cesarean section, always a cesarean section. With this dogma, they noted to have a steady increase of cesarean section rates, especially in the 20th century. WHO recommends a cesarean section threshold of 10%, noting that a higher rate is not associated with improved outcomes, and a lower rate is associated with mortality because of an unmet need for this life-saving procedure. And so as a way of curbing this increased cesarean section rate, various international organizations have recommended a trial of labor after cesarean section as an option for women with one previous scar, and they have to meet a certain criteria. With this, another dogma was coined that once a cesarean section, always a hospital delivery, and twice a cesarean section, then preferably a cesarean section. Of note is that both planned repeat cesarean section and trial of labor are both associated with risk, noting that a failed trial of labor poses more risk to these women and the unborn baby. And the choice of trial of labor has been challenged due to the rising incidence of uterine rupture. And this is due to concerns of both the maternal safety and the fetal safety. And this incidence of uterine rupture is higher in low middle income country, of which Kenya is one of them. Sub-Saharan African, the cesarean section rate is 5%, and in Kenya it's noted to be at 8%, both of which are lower than the recommended WHO recommended rates by the WHO. This raises a concern of an unmet need for this life-saving delivery option. And so previous studies have indicated a success rate of 60 to 80, but these studies are mainly in developed countries. And in developing countries, Senegal and Mali, it was noted to be 44.7, which is lower than the indicated in the developed countries. And success rate varies with huge margin in different setups. So this study was to, we saw a need to generate local data to guide the practice of trial of labor. And this study just sought to provide a glimpse into safety and risk associated with trial of labor. So my research question was, what is the success rate of trial of labor in Tenwek Hospital and Longisa County Referral Hospital, both in Bomet County? And what are the factors associated with successful trial of labor in the two study sites? My objectives were, the primary objective was one, to determine the success rate of trial of labor in Tenwek and Longisa, and the study period was between October and May 2023. And the secondary objectives were to identify the factors associated with successful trial of labor in the two sites, and also to describe maternal and fetal complication associated with trial of labor. My conceptual framework, so a pregnant woman with one previous scar has two modes of option that they can plan to have, either a trial of labor or a planned repeat cesarean section. There are various factors that influence this mode of delivery, and including the medical obstetric conditions, healthcare system or hospital policy, social, cultural, and even the environment. And also these factors affect the actual mode of delivery, which could be an actual vaginal delivery, an emergency repeat cesarean section, or a planned repeat cesarean section. And various adverse outcomes have been, could be noted. So you could have a uterine rupture, hemorrhage with need for blood transfusion, infection, death. And then there's also neonatal factors such as asphyxia, infection, NICU admission, death, and oxygen requirements. So this study was a quantitative study, prospective, observational cross-sectional study. The study sites were Tenwek Hospital, which is a faith-based level 5 hospital, and Longisa County Referral Hospital, which is also a level 5 county government facility. My inclusion criteria included women with one previous scar, single intrauterine pregnancy, gestational age of more than 36 weeks, cephalic presentation, and interdelivery interval of more than 18 months. And then, so this interdelivery period is between the current pregnancy and the previous cesarean section. And then inclusion criteria included exclusion criteria included multiple gestation, more than one previous scar, preterm labor, plastic uterine incision, previous history of uterine rupture, fetal anomalies, and abnormal placentation. So my sampling criteria was a purposive sampling technique, and then the recruitment was done at admission. My sample size was calculated at 160. The data collection, I used a validated questionnaire as described by Kimoto. And this questionnaire was divided into two parts. The first part is containing demographic, history of previous pregnancy, and other relevant past medical history. And then the other part now was outcomes of the current deliveries. Outcomes measures that I assessed included for maternal, it was hemorrhage with need for blood transfusion, delivery trauma, infection, and death. And then for neonatal was admissions to nursery, perinatal, neonatal death, oxygen requirements, seizures, APGAR score, and death. And then I did a descriptive analysis, and then using odds ratio to test for association and chi-square to test for statistical significance. Statistical significance was set at 0.5. So of the 161 women who enrolled into the study, the success rate was at 47.8%. And the most common indication for repeat cesarean section included poor progress and followed by non-reassuring fetal status. The other indications included abruptio, cord presentation, impending rupture, macrosomia, and 13.1% had indication of maternal choice. For outcome measures for the blood transfusion, 9.5% required blood transfusion, with 66% of whom were had an emergency repeat cesarean section compared to the 33.3% with vaginal delivery with a p-value of 0.17. In my study, we did not have any uterine rupture reported, though we had 3 cases of impending uterine rupture. And we had cervical and vaginal tears at 23.4%. And then for infection, we had 9% of cases of infection, 55% of whom had a vaginal delivery, and we only had 1 case of surgical site infection with a p-value of 0.52. For neonatal outcomes, we noted that a majority of those who had a birth weight of more than 3.5, that was associated with a repeat cesarean section. And then for APGAR score, we noted that around 150, that is around 80% of the patients had an APGAR score of more than 7. With around 60% of whom were emergency repeat cesarean section. And then 69% were admitted. Sorry, not 69%. 9% were admitted into nursery, and 69% of whom indications were birth asphyxia and had emergency repeat cesarean section. For analysis of factors that are associated with vaginal birth, we noted that for ANC visits, all the women included in the study had at least 2 ANC visits. That's against the recommended 8 by WHO. And there was no statistical significant difference noted in the mode of delivery between those who had ANC visits of less than 3 and those who had visits of more than 3. We had 3.1% of neonatal deaths, and 40% of whom were stillbirths, and the rest had died due to severe neonatal asphyxia, day 3, 7, and 10 of birth. And 80% of the neonatal deaths were associated with emergency repeat cesarean section. Interdelivery interval of more than 60 was associated, we had a p-value of 0.01, which indicated that it's associated with successful VBAC. And then total vaginal delivery was also had a p-value of less than 0.01, which also indicates which shows a positive predictive value for a successful vaginal birth. The indication for previous cesarean section, we noted that for poor progress was associated with failed trial of labor with a p-value of 0.026, and malpresentation was associated with a successful VBAC with a p-value of less than 0.01. My conclusion and recommendation. So from what I've shared, we noted that a failed trial of labor is associated with poor outcomes as compared to a successful vaginal delivery. That is noted from the neonatal deaths that all had 80% were associated with failed trial of labor, and also the need for transfusion and admission to nursery. And so a careful patient selection will be is recommended so that those who have had a successful vaginal delivery, birth weight of less than 3.5 are selected for trial of labor as compared to those who've not had a vaginal delivery before, and those who've had a birth weight who have a estimated birth weight of more than 3.5. As for my conclusion, we've noted that the success rate is 47, which is less than those reported in the developing countries. As such, there's cesarean section rates should not be thought as being too high or too low, rather than whether the indication is appropriate or not, taking into consideration all the relevant information, considering that in this setting, we're still battling with an unmet need for cesarean section.
And then you can be able to respond to that. All right. So questions to Eunice. So Eunice talked about, Brenda talked about the factors influencing patient satisfaction in Nakuru Level 5 Hospital during the COVID-19 pandemic. So questions to Brenda.
Thank you. So I have a question for Brenda on her study on patient satisfaction. So I wanted to know if in your study, if you employed any qualitative data analysis techniques, such as thematic, for the open-ended questions that you are having from your data, and perhaps how did you deal with this?
All right. Brenda, I hope you have noted that question. So we have another question here.
Thank you, Brenda, for your good presentation. I have a question concerning your sampling. You focused on inpatient. That's medical and surgical. And I know that when it comes to inpatient, again, we have some departments which are very sensitive. We want to talk about labor and delivery, maternity as a whole, okay? And then we also have outpatient. When it comes to waiting time, outpatient services, that's even an area where patients are very sensitive when it's come to waiting time. So
Let me just stand. So the first question is asking about how we conducted the study. So together with how we analyzed the study. So our study was basically qualitative because we understand that satisfaction is highly subjective. It's based on how maybe you view a given service. So our study was qualitative. We asked the patients on their opinion, and we went further to do analysis based on chi-square test to find out the relation between the subjective opinion of the client with how it affects the patient satisfaction. I hope I answered the question. On the second question, I was asked about why we chose the inpatient, specifically the medical and surgical wards. So one of our limitations in the study was time, and also the selection of medical and surgical wards was based on the convenience of the researchers. We were able to assess more clients in the medical and surgical wards, but we'd like to recommend more studies within the special clinics and also the outpatient department. Our limitation was basically time. The medical and surgical wards were purposively chosen for convenience of the researchers.
All right. To Eunice about the cesarean section and outcomes. Okay, so there's a question.
Yes, good morning.
Good morning.
My question to Eunice is just to elaborate a bit on our message.
There's another question.
Okay, thank you. My question is on objective number 3, complications. What was the intent of that objective? Because we already know them in relation to the study area and her study. Thanks.
All right, so Eunice, you can respond to the message and the complications, about the complications.
Okay. So for my take-home message, the success rate here was low, though we cite, usually for our patients, we cite at 60 to 70%. My take-home message is trial of labor is still a reasonable option because close to half of the patients had a successful vaginal delivery. But to have a careful patient, because from what I feel, there are factors that are associated with success and factors that are associated with failure. failed trial of labor. As for the complications, because these are complications that can also occur in a patient who's had no cesarean section. But then I wanted to see, for those who had a vaginal birth compared to those who have a failed trial of labor, how do these complications from this study, what is the percentage of these complications? That's what I wanted to find out. Any other question?
All right, so there's another question here, Eunice.
Yes.
Thank you, Daktari, for your especially as a developing country. Because you'll find that when you talk about this trial of labor, we should be thinking about the personnel, because trial of labor, these mothers will need close monitoring. Okay, we should have the nurse monitoring or the midwife monitoring closely, and the doctor also should be within, so that should anything happen, at least this mother can be taken in for cesarean section immediately. So my question is, did you take into consideration some of these factors when you're carrying out the study? Thank you.
So that was the reason why I thought of conducting this study, because I noted that this trial of labor is offered to women with one previous scar, and we barely met the criteria that has been set by the various international organizations. For example, we barely met the one-on-one patient.
Those questions. You still have one more question, and then we can be able to close that session.
Thank you again for the presentation.
That are associated with success or failure, I put into consideration the factors, the indications for the previous cesarean section. And I noted that if the prolonged labor was indication for the previous cesarean section, it was associated with failure, like higher risk of failure, as compared to if malpresentation, for example, was the indication for the previous cesarean section, it was associated with a higher probability of success. And so, yes, I put into consideration the indications for the previous cesarean section.
All right. Thank you for responding to that. Since there are no more questions, we'll now proceed to the next session of presentations. And this session will be moderated by Mr. Dominic Abungu. So before we get to that session, let's appreciate our presenters for this time. Thank you. Dominic, you're welcome.
Good morning. My name is Abungu Dominic. We are going to have 2 more presentations, but I'm told there's a Sheila that is also ready, who was supposed to present before the coming one. But we'll allow Phyllis to come in, and then Sheila. Then we are going to have Jacinta Wambugu online coming to us. Now let's welcome Phyllis. She has a study on Moringa. This is, I think, going to be an interesting one. Olifera.
Okay, thank you very much. Good morning, everyone. I'm Phyllis Waruguru from the School of Medicine in the Department of Human Nutrition. And I'm going to do a presentation on the impact of Moringa oleifera on the health of people living with HIV/AIDS. This is a review article, and therefore the main goal or the main purpose of this review is just to summarize the impact of Moringa on the health of people who are living with HIV, so that by the end of this presentation, the healthcare professionals can have a clear understanding or a clear guidance on the use of Moringa and what role or impact it plays in the life of people who are living with HIV/AIDS. Now, just a brief introduction. Prolong the life of people who are living with HIV. However, as I said, this HIV is still a condition of major concern, and especially in areas where we have limited resources and access to healthcare and treatment, it may continue being an item of concern. Due to reasons well known to us, including the side effects such as nausea, some use the traditional methods. And one of those traditional methods is the use of Moringa. And Moringa will be one of these traditional herbs that is widely used by the people who are living with HIV. Sadly, or unfortunately, is that this herb is mainly prescribed by the untrained personnel. And the main reason as to why it's prescribed by the untrained personnel is because there is so much controversy in the impact of these who are living with HIV. So I used a general method to do a review on this. I did an analysis or collected data a number of publications, which I searched in these databases. And this review was done between the 1st of July to 31st of August last year. So original clinical trials, that is the that were working with human beings and must have been published in English. And then we also did a bit of citations in cited articles. And some of the keywords we used were searching for this and Moringa Health, RCT methods, all data collection method. So the connection process, we managed to retrieve a total of 20 articles. Out of these 20 articles, 11 were omitted since they did not meet the inclusion criteria. So the remaining 9 articles were analyzed, and we harmonized the data and summarized in a table that clearly finding of our study. I don't know if you can read from, but I'll take you to this what from these. All studies in this review, they adopted the RCT study. The hypothesis was that information about Moringa has been documented. So it was hypothesized that Moringa, which is rich in antioxidants, which play a key role in boosting of immunity, it was hypothesized that it will improve health indicators of these individuals. And from our review, we were able to document or to see that higher doses of Moringa increase the efficacy or the impact of this. So, cell count. We documented that those individuals who consumed Moringa, the CD4 cell count increased. And also the BMI, that is the body mass index, we were able to find those participants who consumed Moringa an improvement in their BMI status. What about psychological well-being? Is important in the health of persons. Well-being is that those people who consumed Moringa documented or showed that was in their psychological well-being. What about depression and anxiety? The management of depression and anxiety, which is very common. So they are depressed or they're anxious about their life. What about the organ function? We were able to see that Moringa supplementation also improved the functions of vital body organs. What about the cholesterol levels? Again, Moringa plays a key role in improving the cholesterol level of this individual. So what is the discussion behind these findings? Under the body mass index, we assessed 3 studies. We used Moringa leaf powder as the intervention, and 2 studies showed that BMI, there was an improvement in BMI. However, 1 study indicated that there was no improvement in BMI. Why the variation? So the increase in BMI was attributed to the nutritional value of Moringa, which is very rich in protein. And know that protein plays when it comes to the BMI of individuals. However, the 1 study that documented no significant improvement in the BMI, we were able to show that, number 1, the study used very small doses of Moringa, so probably it did not meet the minimum requirements. And also, the participants in this study had got a higher BMI. Most of them were already overweight and obese. So to detect the change in BMI. That's why they concluded there was no significant improvement. Then under the CD4, there was significant increase in CD4 across all the studies that we reviewed, and this could be attributed to the fact that moringa is a key role in improvement of the immunity. Then also, the participants in these studies had low CD4 counts, and therefore the fact that they consumed moringa, it contributed to an increase in the CD4 cells. Then also the nutritional components, as I said, moringa is very rich in both micro and macronutrients. Under the micro, it involves both minerals and the vitamins, which play a key role in the immunity of the body. So that is also the same explanation under immunological influence, which the parameters checked were the white blood cell, the red blood cells, the platelets, and all these, they increased with the use of moringa. So that was attributed due to the presence of the oxidant. So what were we to conclude from this study? We concluded that if moringa can be used along ART, this study does not document or does not advise us to stop using ART. In addition with moringa, we are likely to improve the health of these people who are living with HIV. So what are some of the recommendations? So considering moringa supplementation among HIV to optimize their health, we recommended that it is important to carry out scientific research, particularly focusing on the viral load. We have seen that moringa do have a positive impact on other health indicators. But when it comes to HIV, viral load is very crucial. It is the main indicator that we use to assess the treatment or the success of HIV treatment. So we highly recommend a research to be carried out if moringa or ifena will have any impact on the viral load suppression. And therefore, we do ask or encourage organizations to support to fund such studies so that we can ensure the health personnel advising people, they can confidently advise or they have the stance behind it that moringa can have an impact on the viral load or not. And that brings me to the end of this presentation.
We can keep the question. I hope she's ready. Okay. She's going to present online. So you can step on. Okay. This is Jacinta Wambugu that's going to present online. Sheila is ready. Yeah, Sheila.
Oh, okay.
Am I audible?
Go ahead.
My name is Sheila Sharon. I will be presenting about the passive determinants among undergraduate students at the university. With the help of providing supported by the Department of Nursing, has become a stress has become a growing global dimensional concept which has taken the form of an epidemic. It is a common psychological issue among learners worldwide. Stress is any type of change that Elizabeth Scott. It can predispose one to problems and can cause alteration of health status, which may affect individual performance and social well-being. Among the stressed nations that we have globally, we have Afghanistan being the top 24%. Among the countries which are least stressed, South Africa 27%, according to the development report in 2019 and 2022. If stress among the undergraduate students, there is a relationship between stress level and academic performance among university students. Stress, according to China, 2015, causes deterioration in academic performance characterized by low inability to complete assignments. Our problem stress among undergraduates is a major problem in most universities, despite its impact on different aspects of life. Specific determinants of stress among undergraduates, it remains unclear. And in the Counseling Department of Kabarak University Students Organization, in conjunction with the Dean of Students, it started a mental health campaign, which had a title of "It's Okay Not to Be Okay." The aim of the campaign is to enhance students' mental health and emotional well-being. And according to the statistics, the mental health and wellness campaign, the counseling department indicated that approximately 10% of the students to having experienced stress or stress issues. According to the According to the Kenya Mental Health Policy 2015, mental health policy 2015, the health for all policy.
So we give her a hand to see if she can get through. Wait for if I not is in line.
Yes, I am. And according to Rudolph 2013, it was also conducted in line with the Health for All policy and the Vision 2030, which is a collaborative strategy to improving the health of all communities and people, including university students, by integrating and articulating health considerations into policies across sectors. Our objectives, our general objective, the study sought to determine the perceived factors that contribute to stress among undergraduate students. Specific objectives. The first one, to determine demographic factors that contribute to stress among undergraduate students, to identify psychosocial factors that contribute to stress among undergraduate students, to assess the institutional factors that contribute to stress. The next slide. The methodology, the research design, we used a descriptive cross-sectional design. This approach allowed for the examination of quantifiable perceived factors that influence stress, such as age, gender, academic performance, and social support. The next slide. The study was conducted in Barak University, a private Christian university located in Rongai sub-county, Nakuru, in Kenya. The study population, all eligible undergraduate students that were registered in main campus and gave consent during the study period. The sampling frame was a total of 9,030 registered students according to the Kabarak University records. This is the distribution according to the 7 schools. This was the records for 2022. The sample size determination, we determined using the Confrence formula in 1977 as stated in the Harris et al. 2018. And 344 participants were included. The next slide. The next slide. The next slide. The sample size and sampling technique. A stratified sampling was used to select a representative sample of 344 from the target population of 9,030 students in 2014. Our research findings, according to the demographic characteristics of the study subjects, the response rate was 98%. The study had 337 participants, all between the age of 18 to 25 years old. Majority of the participants were male, 56.7%, and female, 43.3%. The Christians, 95.3%, and a small percentage of Muslims, 0.3%. The first-year students were 49.9%, followed by the fourth-year students, 29.6%. The next slide. This is the table of the analysis of the socio-demographic characteristics of study subjects according to the age, the gender, financial support, religion, and the year of study. Next slide. These are the findings that those of participants that had experienced stress, and also the causes associated with stress, including academic pressure, health, bereavement, relationship issues, and financial issues. The description of different causes of stress among the study subjects. The next slide. These are the personal determinants as source of stress among study subjects, which are combining job with studies, change in the living environment, change in sleeping habits, new responsibilities, financial difficulties, health problems, and poor eating habits. The description of the stress manifestations among study participants, like feeling tired during the day, cannot sleep at night, and occasionally do not feel well at times. These are examples of the coping mechanisms that the study participants gave us, like watching movies, sleeping, crying, playing sports, talking to a friend, and the additional factors. Institutional factors, most of the study participants say they are experiencing a lot of pressure from the academic calendar, which most of them were 86% of them. And this is a table showing the influence of stress on academic life. And the one which has the highest ratings had 33% of the students influence stress on their academic life. Confidence intervals, characteristics. The fourth years had the highest number of the participants, and our progress less than the 0.0. Next slide. Next slide. So this was an example. Third year students and fourth year students did not show significant association with stress levels, except for fourth year students who had an odd ratio of 1.87. And in the stress group, the most in the not stress group with a statistically significant 0.045. So
showed higher odd ratios levels. None of the associations reached statistical significance in this analysis. For our discussion on demographic factors, the findings on gender showed that more male compared to female are more stressed. The students are mostly stressed at the one in their first 49.9% had the highest turnout compared to the ones in other years of study. The discussions on the psychosocial factors, majority of participants coped with stress by talking to friends or watching movies and videos. This finding is conducted by Nadim et al. In 2021, which found that the social support from friends and family was an effective mechanism for stress among undergraduate students. Financial problems was a significant stressor for many participants, with 70% of the students reporting financial difficulties. This finding is consistent with the study conducted by Oketo-Both and Okunya in 2018, which identified financial problem as a cause of stress among undergraduate students. Financial problems and academic pressure were more common at 34.1 and 38.6 respectively among the first-year students.
Recording in progress. The discussion on institutional factors, various academic factors, such as crowding in the home semester grading system, sufficient facilities, long hours, and rote learning requirements have been found to cause stress among undergraduate students, as cited by Debet early in 2015. The findings indicate that 86% of undergraduate students feel the pressure from academic calendars, while 14% are not affected by it. Short holidays and too much workload are among the factors that cause stress. So for students to balance academic work and leisure, students often use timetables to plan their schoolwork effectively. So effective planning can reduce pressure from academic workload and improve academic performance. Overall, while some characteristics showed higher odd ratios for stress levels, the association was not statistically significant, except for the fourth-year students that was statistically significant. So our conclusions: personal determinants such as change in sleeping habits, planning, considering the new student abilities, and combining jobs with academic activities were found to be among the perceived causes of stress among undergraduate students. We also have the psychosocial factors such as social support, negative effect, perceived health status, and coping skills significantly influence stress levels among university students. Academic pressure is a significant source of stress among university students that is linked to reduced academic performance. Stress management techniques such as effective planning, seeking guidance and counseling, and stress awareness education can help reduce stress levels among university students. Recommendation: universities should provide adequate resources. Universities should provide adequate resources and facilities to support students' academic and personal needs, including plan orientation and mentorship programs upon admission to campus, enable ease in adjusting to the new environment. Educational institutions should consider implementing regular stress management, education, and awareness processes to give students with necessary assertive skills such as time management. Universities, through schools and departments, should promote and implement a supportive environment for students. Academic advisory and mentorship should be focused towards a whole-rounded approach to students and not purely on academic preparations. Institutions of higher learning institute student-centered pedagogical strategies to enhance students' interest for academics and enhance classroom participation, which will enable learners to feel pressure to learn or attend classes. Study to assess the actual prevalence of stress among students from different cohorts or schools to identify unique causes of stress in the respective cohorts. Thank you.
Let's have the last one for questions. And I have Jessica, you are ready now?
Screen.
Sure, go ahead.
I hope it's visible.
Not yet.
Continue?
Yes, please. It's yours.
Okay, thank you. My name is Jacinta Wambugu, and I'm a student at the Department of Human Nutrition at Kabarak University. And I'm grateful for this opportunity to share my study, which was on the determinants of non-compliance to iron and acid supplementation among pregnant women who are attending antenatal clinics in Nakuru North Sub-County. So micronutrient deficiencies, which are also known as hidden hunger, because unlike other deficiencies, they're not always manifested. And the most common micronutrient deficiencies are iron and folate due to the increased maternal and fetal requirements. Anemia in pregnancy has also been shown to be a leading cause of global burden of disease and therefore causing significant diseases and mortality. And the prevalence of anemia in pregnancy has globally been shown to range from between 41.8 to 43.8%. Here in Kenya, it remains a public health problem, and the prevalence have been documented to be persistently high, up to 55%. And one of the measures that, or the interventions that have been put in place is iron and folic acid supplementation, which has been seen to be affordable and effective global intervention. Because during pregnancy, the high body's demand for nutrients is not met by regular diet because of the insufficient availability amounts of nutrients in the diet. And these are according to NISA and Deeply, who conducted a study in 2014. The daily intake of folic acid supplements during pregnancy have been shown to help in reducing the overall risk of anemia by up to 70% and up to 57% for iron deficiency anemia, according to a study that was conducted by Lavana in the year 2020. In the year 2012, the WHO guidelines of iron and acid, which Kenya targeting to achieve at least 50% coverage. However, compliance to This supplement remains low over the years, and according to the Kenya Demographic Health Survey of 2014, it showed that only 8% of pregnant women were taking the iron and folic acid supplements for more than 90 days. While in actual fact, they were supposed to be taking it for the entire pregnancy period, which is 180 days. Studies conducted in Machakos and Kiambu by Juma et al. And Kamau et al. Showed that only 18% and 32.7% of the pregnant women were compliant with supplementation. A study conducted a survey that was done here in Nakuru County in the year 2020 showed that the mean consumption of IFAS during the entire pregnancy period was only about 58 days. However, despite the non-compliance that is seen, there is information on the reasons for why the compliance is so low in Kenya. The objectives for the study included to assess the demographic and socio-economic characteristics of women attending antenatal care in North County, examine the prevalence of the IFAS non-compliance, to determine the matter of that IFAS non-compliance, and also to health facility that were influencing non-compliance. To establish the level of pregnant women, and lastly, to determine the association between the demographic, socioeconomic characteristics, the hemoglobin levels, and iron and folic acid non-compliance status. So why is this study significant? This study, the results will assist the policymakers in designing appropriate strategies to aid in achieving good compliance of the supplements. And while the health workers will be able to provide targeted counseling, and as they will be able to highlight the factors that it will influence IFAS compliance. And to finally contribute to knowledge in studies which are geared towards mitigating iron deficiency anemia during pregnancy. The literature review was done, the overview was on global perspective of micronutrient deficiencies, iron deficiency anemia in Kenya, strategies of addressing iron deficiency anemia, social demographic and socioeconomic factors, prevalence of IFAS compliance, and factors associated with non-compliance. And through the reviews, I found that for decades, there has been raising awareness of the magnitude and seriousness of iron deficiency anemia, as well as increased commitment to alleviate it. For the conceptual framework, the independent variables included maternal factors, facility factors, demographic and economic factors, while the independent variable was the IFAS non-compliance status, which was defined as the pregnant woman having taken less than 5 tablets per week. The design was the study used a mixed method of cross-sectional study design. Being a mixed method, the methods were both quantitative and qualitative. The study site was Nakuru North County. The pregnant women between 18 and 49 years. The inclusion criteria was one had to have attended at least one antenatal clinic, and the study included those who are severely sick, those who 18 years. The calculated sample size for the study was 179, and the sample used was both purposive and systematic sampling. The study used structured questionnaires, and for the qualitative part of it, 8 focus group discussions and key informant interviews were conducted. For the validity of the tools were done by having them reviewed by nutrition professionals, while the reliability was tested using the Crobert alpha test. The data collection procedures, the questionnaires were researcher administered. Then we had 4 focus group discussions and 4 informant interviews conducted. For the hemoglobin status of the mothers, this was obtained secondary information from the mother child booklets. Analysis used SPSS version 21 for the quantitative data, which did distributive statistics, focusing on frequencies and percentages. A chi-square to ascertain the significance of association using a p-value of 0.05, and odds ratio was done to quantify the strength of association with non-compliance and selected variables. For qualitative data, mathematical analysis was used. In terms of ethical considerations, the study was cleared by Kabarak Ethical Committee, and a research permit from NACOSTI was also gotten. The participants had to have given informed consent. The participation was voluntary, and confidentiality and anonymity of the participants was ensured, including data safety. So what were the results of this study? In terms of demographic and economic characteristics, total respondents were at 92.5%, and most of them were between the ages of 20 and 29 years, with a mean age of 27.69%. There were 83.7% were Protestant Christians, majority were married and had between 1 and 3 children, and 41.5% were housewives, with only 47%. The prevalence of IFAS non-compliance in Nakuru North was ascertained at the non-compliance was 7.1%, while the those who are compliant was 22.9%. And the reasons they gave for the non-compliance were the majority of them cited side effects, followed by not liking the test, and also the issue of stockhouse capabilities. In terms of the maternal factors, the study was able to show that 37.6% were not complying because of side effects, and even in one of the informant interviews, one of the respondents stated that some have stopped because they cannot tolerate it due to side effects. The mothers really don't like the taste of IFAS. Another maternal factor identified was late antenatal visits, with only about 20.2% going for the first ANC when they were in their first trimesters, 2 months pregnant. And in one of the focus group discussion, a mother stated that most pregnant women start getting antenatal care for the 4th month. Some it is because they did not know they are pregnant due to previous irregular pregnancies. The factors, the facility factors identified included issues of supply, with 13.2% stating that they had not received the iron and folic acid tablets at the clinic. And the other factor identified was the issue of counseling, where 1.8% stated that they not received information about the benefits of the supplement at the healthcare facility. In fact, one of the respondents in the focus group discussion stated, "For me, I do not know of IFAS. They were just prescribed to me by the clinic doctor." From the mother child booklets, the hemoglobin level, majority of them are seen to be in the normal range, 7%, having between 11 and 15 grams per deciliter. In terms of the associations, there was a significant relation between the demographic, socioeconomic characteristics, hemoglobin levels, and compliance status. There was also a significant relationship between compliance status and hemoglobin levels, but the study noted no significant relationship between the compliance data and some of the demographic characteristics, such as age, religion, marital status, occupation, and number of children. The odds ratio computed showed that respondents without side effects due to the intake of IFAS were 100 times likely to comply and those with side effects. Mothers who had started their periods early were 1.33 times more likely to comply than those who came in late, and also that a constant supply of vitamins at the facility made 1.24 times more likely to increase compliance. In conclusion, the study noted that majority of the participants were married young adults, and that the prevalence of IFAS non-compliance was relatively low compared to other studies that had been done previously at 27.1%. Maternal factors identified included side effects, latency visits, while the facility factors included stockouts and counseling. The hemoglobin levels were mostly in the normal range, and that there was a significant relationship between IFAS compliance status of the pregnant women and their hemoglobin levels. From this study, recommendations is that a review of the advice given to pregnant mothers visiting or going for their clinic in a community should be up-to-date, comprehensive, and impactful so as to influence positively IFAS compliance, and efforts be developed at county level to capacity build health workers so that they are able to forecast IFAS requirements and therefore avoid stalkers. We also need to have an intervention study to establish the impact of the iron and folic supplementation in reducing iron deficiency and prevalence among pregnant women in Kenya. So finally, I would like to acknowledge the guidance and support that I've gotten from Dr. Peter Chege and Miriam Muga of Kabarak University. Thank you.
Thank you very much, Jacinta. A louder clap. Yes. So, Jacinta, to be attentive to the questions that we can, and beginning with give a mic. So you introduce yourself and then ask a question. Phyllis, you want to start or you take them from there?
Good morning. My name is Doreen Chipto. I do nursing, stroke clinical nutrition. I have a question about moringa. Despite the youth benefits and information about moringa, I have. Do you consider the side effects of moringa?
are some of the interactions that you find out in terms of nutrient interactions, which I think will be related to what our student has just asked. Then secondly, these patients are usually on ARVs. What are some of the nutrient-drug interactions? And I'm thinking in terms of the antagonistic, synergistic.
You?
Okay. Thank you. My question is on, thank you please for your nice presentation.
Related, you did a systematic review of documents, and I see you said you did only 20 articles, and then out of them 11 were not related to your study. With the systematic reviews, do you think that number of 9 articles would be enough to have a threshold to inform your findings, given that there's a lot of studies that have been done? And in relation to that, what search engines were you using to give you a wide coverage for, because those are very key things in systematic review, so that you can cover as wide as possible, so that you can come with the conclusions that you have. And then were these studies regionally, or which areas? Because Moringa is used in quite a number of countries. I think those are the 2 questions for you. Let's come to Sheila. Questions for Sheila. You have a question for Phil still. There's one more question from Doc.
Thank you. Phil did present a very good study, a systematic review. Regarding CD4 cells, anytime patients are on ARTs, they are also on supplementation. So it's a supplementation that usually
There's one there, and there's 2 here. Maybe we start from her, then we come to you. Oh, No? Oh, here, come to Dr. here. Okay, whichever. Jacinta, a question for you.
There's a question for Jacinta. She did 4 key informant interviews for her study. Now, for qualitative studies, usually when you're doing interviews, available literature show that you do a minimum of, or saturation will be reached at a minimum of 10 interviews. But in this case, she did 4. Does it mean that by the time she was doing the 4th interview, she had already reached saturation? And how, if that's the case, then what makes her study significantly depart from the trend of other studies, qualitative studies? Thank you.
Thank you. Any more for Jacinta? Okay, Jacinta, I have no. You have, okay.
Okay. Okay, thank you. In terms of the duration and how you went about analyzing your data, and I'm adding, synergizing what Doc has mentioned about saturation. Did you meet the threshold to make your study more crucial?
How did you identify which students are showing signs of stress? I think that's the question I have for Sheila. So if there are no more other questions, let's begin with Phyllis. You can respond. Oh, there's one for Sheila.
I would like Sheila to elaborate on the common stressors in her study.
Center, are you?
Yes, I am.
You can respond to your questions.
Yes, thank you very much. I think I noted two questions, both of which were revolving around the methodology of the study. For the first one about the key informant interviews, the study was actually hospital-based, and the sampling for the key informant was purposive.
We chose the students. We chose all the students, and we didn't identify the ones who had stress. They are the ones who gave us their own perceptions of how they are feeling about themselves. We didn't use any tool. And the common stressors that we had that caused stress mostly was financial issues and the academic calendar. So about the academic calendar, studies required for a proper assessment of stress among the students to establish an actual determinants to those who are stressed using the specific tools. We have various tools for studying stress, like the MASLAC tool. We also have the perceived scale tool. And also for the nursing students, we also have the nursing stress tool. Yeah. And I'm sorry about the previous hitch we had with the internet issues. I'm sorry about that. Thank you. That's all.
It's okay, thank you. I think we can clap for the presenters. They've done a good job. And we want to welcome Piers to take over from me to handle the next session.
Department of Human Nutrition. I'm going to be the moderator for this session. I must say that I'm holding brief for Dr. Moga. So in these next presentations, so I can see we have the first presenter here, but I was just wondering whether we have somebody locked out, somebody who was supposed to present in the previous session. I'm not sure about Jeremiah Okari and his availability. Okay, if not, I would like to request and invite Dr. presentation. It's a very interesting presentation here, so I would urge you to be very keen. The main projector, IT. So our IT people, come and connect the Dr. Aleko's presentation to the main projector before. So then after Dr. Waleko's presentation, I hope we have Salome ready to present her abstracts, and then we can have a question-answer session for both. There we go. Thank you.
Thank you. Good morning. Good morning. My name is Michael Walekwa. I am an MBA student in this university. So I'll be presenting my proposal. And the reason I'm presenting is so that I can get views from participants. So this is still work under progress, and I invite all of us to listen carefully. So the topic is influence of total quality management practices. But I can try. I hope I'll. Is that better? Yeah. Yes, I was saying about 70 to 90%. Of course, the need for the laboratory results to be accurate. However, the current state of quality management practices, which usually ensures that the laboratory results are accurate, that state is not very clear. I will explain something called TQM. TQM is total quality management practices. whereby an organization ensures that every employee is involved in ensuring that the vision and mission and objective of an organization are met, or the services or products of an organization are efficient. That's TQM. For you to achieve TQM, total quality management, there are about 8 elements that I have listed over there: strategic management, continual improvement, customer focus, total employee involvement, process-centered, integrated system, fact-based decision-making, as well as communications. I'll be able to elaborate on these elements a little bit later when I'll be discussing the conceptual framework. Now, total quality management is essential to address inaccurate medical laboratory results. But before I explain this, data are very you can actually test positive for COVID when you're not, in actual sense, having COVID. Statement of the problem: inaccurate lab test results in Kenya pose serious concerns, especially in critical areas such as cancer, tuberculosis, malaria, and STIs. High rates of false positive and negative outcomes in these diagnostic tests have been observed, leading to detrimental consequences for patient care and public health initiatives. An example is false results can result in misdiagnosis, and so you get treated for the wrong thing. And when you're getting treated for the wrong thing, it means you are paying, because healthcare in this country is quite expensive, just like it is elsewhere. So you've been diagnosed for the wrong thing, and therefore you're being treated for the wrong thing. Increased healthcare costs and compromised disease control efforts. The knowledge and understanding of TQM practices in laboratories within the county of Nakuru is either limited or unknown. Actually, when you look up online, in all databases, there's no documented information about whether our laboratories are implementing TQM practices or not. That information is not there. But if you go to the individual websites for certain laboratories, that's where you can get some scanty information. The knowledge gap hinders the implementation of appropriate interventions and improvement of lab processes and procedures. A comprehensive study is therefore needed to investigate the current status of TQM implementation in selected medical laboratories within Nakuru County, and this will be leveraged to be able to address other similar issues in laboratories around the country and even in the region. The objective is to establish the impact of the implementation of TIC-M live below $1 a day. And therefore, they are likely to only seek for healthcare in smaller healthcare facilities, which thereof host smaller laboratories. Unfortunately, the TIC-M platform in this kind of labs, the information about them is not available. Lack of studies investigating the impact of TIC-M practices on the strategic competitiveness of diagnostic labs in Nakuru County, that data is not there, and also need for more qualitative research to explore experiences and perceptions of lab managers and employees regarding TQM implementation. Methodology. Number one is research design under methodology. This is a mixed methods study, so the research type is mixed methods, whereby qualitative data independently, and therefore, at the end of the day, you correlate both to check if there is congruence between the two. Location of the study is Nakuru County, so laboratories within Nakuru County. Of course, these laboratories have been purposefully selected, both private and public. Nakuru County is the key area, the key hub of the Rift Valley region. And of course, that means that it is a major area that would give us the best data. Population of the study, the target population will be operational staff, so people who are involved in the day-to-day running of laboratories, the guys on the bench, and quality officers. So we have quality officers in our laboratories. There are some labs that will have quality officers. There are some labs that will not have quality officers. And these are some of the things we'll be looking at. Heads of sections and managers of selected diagnostic laboratories within the selected, the target area. Inclusion criteria is employees registered with KMLTTB. KMLTTB is Kenya Medical Laboratory Technicians, the Technologies Board. So anybody who will not be registered by this body will not be selected. Employees for at least 1 year, so you should have worked at that lab for at least a period of 1 year, and participation will be voluntary, so we will not coerce you to participate. Exclusion criteria: declined, anybody who declines to offer informed consent, and anybody who would have served for a period of less than 1 year at the selected lab. Sampling technique will be expert and homogeneous sampling. This is we'll be doing positive sampling, whereby we come to the lab that is selected, and any employee who meets, because laboratories don't have so many employees, so maybe a lab can have 10 or 15. So anybody within that laboratory that meets the inclusion criteria will be picked. And of course, we will be sampling 5. I'll be sampling 5 laboratories within Nakuru County. This is Lancet Pathology Laboratory, Scan Lab, PGH Laboratory. The first 2 are public, the first 2 are private, then 3 public, PGH, Bahati Sub-County, and Naivasha Sub-County. Out of this, for quantitative, we'll have a total of 48 subjects. For qualitative, we'll be doing interviews, using interview guides, up to a point when we reach saturation. And the minimum information that we know from literature is majority of the studies will reach saturation point. Saturation in this case means that you are not getting any more new information. So you have been interviewing people about a particular topic, and you have reached a level where you're not getting any new thing, so you stop there. So we expect that saturation will be reached after we have done a minimum of 10 and a max of 30. Instrumentation, structured questionnaires will be used to
Okay, so the presenter going to do it online is Sheila. Sheila, if you can hear me, and if you are ready, we are ready to do your presentation.
Yes, I'm ready. Can you hear me?
Yes, we can hear you clearly.
Okay, let me share my screen.
Please go ahead. So we are trying to ensure that your screen can be seen from this side.
Yeah. Is it visible now?
Not yet, just a moment. Yeah, sure. Sheila, go ahead.
Okay, good morning. My name is Sheila Naserian. I'm Goitwe. I'm going to take you through my proposal, level of micronutrients affects pathophysiology of diabetes mellitus, scoping review. Just a minute. Okay, into my introduction, diabetes mellitus continue to represent a significant public health concern across the world. There are 4 million diabetes globally, and by 2025, the figure is likely by
it you may need to edit Zoom presentation. PowerPoint when you're not on Zoom.
Can you hear us?
Hi. Yes, I can hear you. What's going to PowerPoint? Doctor is going to and then from where you that is North America, South Central America is going to Africa. It's up to 30% according to government and individuals are likely to spend a colossal amount of money, efforts to improve the disease prognosis and prolong life. Globally, over $27 billion is injected into management of diabetes. in Africa, 3.4 billion in 2015 was injected in managing diabetes, which will then rise to 5.5 billion in 2040. That is according to the National Diabetes Federation. Kenya has an average of 4.6% of their GDP, that is domestic product, on the healthcare, that is according to WHO 2009. With the projected upsurge in the prevalence of diabetes, the risk of poverty and compliance is high, at all times high. Therefore, intervention visible enough to reverse this is a worrying statistic. Therefore, we must be immediately explored. Several interventions to manage diabetes have been exploited. This comprises the intervention, consistent physical activity, health education, intake of medication. While these medication constitute the most important intervention, now the patient participation power has remained a significant hindrance. Therefore, the case fatality rate has become high. The lack of cost necessary to assess motor and safe training severe gymnasia will be prohibitive. Better management continuation of adequate exposure seems to be most promising. While being positive of macronutrients in the dynamic of diabetes, fundamental setback effective management, that's according to Confrence et al. Of great importance, there is really lack of adequate knowledge on the role of micronutrients, that is in the pathogenesis of diabetes. Therefore, the purpose of this study is to describe the role of micronutrients in the pathophysiology of diabetes mellitus. Our research methodology, systematic review was used. Eligibility criteria, all articles published after January 2012, all articles that involve role of macronutrients in management of diabetes, all articles published in English language, all articles published in highly referred and peer-reviewed journals. Information sources are medical databases, which included the ResearchGate, PubMed, Elsevier, and this is between the 20th June 2021 and 28th July 2021. Such criteria for the articles, those diabetes mellitus, macronutrients, that is selenium, there's potassium, phosphorus, magnesium, zinc, and copper. Also diabetes and macronutrients and diabetes. Selection of the studies are conflict of interest, affiliation of the author, research designs, type of data, and the language use. The results were the first article, that is alteration of the topic, alteration of several elements in patient with type 2 diabetes. Cross-sectional study design was used, where a total of the 1837 participants was involved, 637 males and 1,200 females. Out of the 1837, 510 participants had type 2 diabetes, while 1327 were non-diabetic. A total of 19 trace elements were assessed. The copper, the elements that were assessed were copper, zinc, selenium. The factors which are associated with type 2 increased in zinc, selenium, and copper. And these factors included age, BMI, systolic and diastolic blood pressure, and serum insulin. Magnesium also significantly increased the HbA1c, with 7%, and there were no differences when HbA1c was less than 7%. But when it was above 7%, there was significant decrease. Copper and zinc significantly increased HbA1c, that is above when the HbA1c was greater than 7%. And selenium significantly increased in HbA1c when the was greater than 6%. In the other article, effects of chromium supplements of blood glucose, hemoglobin, AIC lipids profile, and lipid oxidation in type 2 diabetes. Experiment that was used was experimental study. Design was used. It comprised of 100 participants of type 2 diabetes that was selected randomly, divided into 2 and placebo groups. Out of 50, 43 completed the study, 7 did not. The age of the subject ranged from 40 to 70 years. The study group received 200 of chromium picolinate capsule 2 times a day for 12 weeks. Consumption of chromium by type 2 significantly reduced. Fasting blood glucose, that is, had a prevalence of or equal to, less or equal to 0.1, and HbA1c a prevalence of less than 0.001. Another glycemic, with a topic glycemic control, macronutrients, and some metabolic enzyme activity, type 2 diabetes. A case control design was used. The study had a total of 100 subjects. 50, so out of the 50 type 2 diabetes, 32 were male, 24 were female. And in the other 50, that was in the non-diabetic subjects, 28 were male and 16 were female. There was no significant increase in of calcium and iron and vitamin C. And in phosphorus, there was levels reduced among the diabetic patient, when you compare to non-diabetic patient with a prevalence of less than 0.05. Calcium level increased with increased age, also for phosphorus levels,